Good afternoon, good morning, colleagues. My name is Professor Flavia Senkbuge. I'm the Deputy Dean, Stakeholder Relations at the Faculty of Health Sciences at the University of Pretoria in South Africa. And I'll be the moderator for this session. And I would really like to warmly welcome all of you, our distinguished guests, our friends, our colleagues, and all our champions of health, of gender specialists joining us from across the world. It's really my immense pleasure to welcome you, all of you, to this high-level event, which is co-sponsored by the Government of France, the Government of Liberia, and Women in Global Health. And I do want to say that throughout this 90-minute webinar, we want to hear from you. So please introduce yourselves in the chat and also send your questions for our speakers. You're also welcome to share your thoughts on our Twitter using the hashtags that we've put in the chat. And please make sure that you are sending your chat messages to under everyone and not to panelists. Otherwise, it will be us, the panelists, who are receiving your message. So please make sure that you send your message under chat messages to everyone. There is also an option to adjust the setting on the chat box. So the review theme of this year's Commission on the Status of Women is Economic Empowerment, and it is under this umbrella that we convene here today. As we enter into the third year of this global COVID-19 pandemic, it really is more important than ever before to bring to the forefront the important issues surrounding women's economic empowerment in the health and care sectors. Women have had to bear the brunt of increased unpaid work, not only in their roles as formal health and care workers on the front lines of health system, but really also outside work. They've been caring for children, they've been caring for relatives. And so the Gender Equal Health and Care Workforce Initiative is co-sponsored by the Government of France and Women in Global Health, and it seeks to create a health and care workforce that is gender equal, where women, who, as we all know, make up 70% of this workforce, are protected from violence and harassment, and they receive equal pay. And so really today, we will be hearing from inspiring and exceptional women in leadership positions in their organizations and in government. And so without much further ado, I'd like to introduce you to our first guest, Ambassador Delphine O. She is Ambassador at Large and Secretary General for the Generation Equality Forum, which many of you would know as the Beijing Plus 25. She led the organization of the largest international summit for women's rights since 1995, which was convened by UN Women and co-chaired by France and Mexico. She was previously a member of parliament for La République en Marche, and she was elected in Paris. She's a French-American Young Leader of 2019, Munich Young Leader 2019, and member of the Council at the Council on Foreign Relations. She's also a member of the Strategic Orientation Board of the German Marshall Fund of France, and a board member of IRIS, which is the Institut de Relations Internationales et Stratégiques. Delphine, the floor is yours.
Thank you very much, dear Professor, for this extensive introduction. Bonjour à toutes et à tous, dear Minister, dear Ambassador, dear Magda, all of the speakers and participants. I am delighted to be with you today to open the Gender Equal Health and Care Workforce Initiative event on the sidelines of the CSW 66. First, I would like to recall 2021, last year, which marked, as you said, an unprecedented international feminist mobilization in the framework of the Generation Equality Forum, which I had the chance and the privilege to lead as the Secretary General for the French government, together with UN Women and Mexico. 26 years after the Beijing conference, it was long overdue that we, together, the international community, recall and renew our commitments, and that we act so that gender equality is not just a dream. The Forum has promoted and launched a large number of initiatives that will pave the way for a more equal future. During the next 5 years, all of the Generation Equality Forum action coalitions will make sure they drive changes in their specific area while taking into account cross-cutting issues, such as transforming gender norms, law and policy reforms, education, intersectionality. I happened to be in New York just last week for the actual CSW negotiations. Physically, it was the first time that we were reunited since 2019. And I have to say that the mood is upbeat after 2.5 years of pandemic. There was an important event organized by UN Women, a 24-hour online event to celebrate 8th month of Generation Equality Forum, and specifically to present the progress that has been made since the forum in June of last year. Among the initiatives promoted at the forum, of course, what we're here to talk about today, the Gender Equal Health and Care Workforce Initiative, has managed to mobilize at all levels and all over the world. And I think today's panel is proof of that. Along with the COVID-19 crisis, it has raised awareness of the fundamental role played by women health professionals in health systems and the strong inequalities they're still facing. So we should definitely be congratulating ourselves for this momentum, for this new initiative, and for the progress that we have made since July of last year. But we should also be working in engaging new partners in this initiative. On behalf of France, I would like to thank all of the partners who have contributed to this success. But beyond this awareness, there is still a long way to go, and we collectively need to answer the following question: how can we actually impose change? The issue of economic empowerment here is fundamental. Women disproportionately affected by poverty, discrimination, and exploitation. And this is particularly true in the health and care sector. It often condemns women to precarious and poorly paid jobs, and allows only a small minority of them to reach positions of responsibility. And we all know, unfortunately, that the COVID-19 pandemic has made this situation only worse. Addressing the issue today, the intersection of economic empowerment and health, in this conference is crucial. In our view, at the government of France, economic empowerment of women health workers will determine our ability to sustainably strengthen health systems, to better prepare for future pandemics, and to enable all people to have access to quality health care. Besides, economic empowerment is at the heart of the triple dividend in terms of 1, benefits for health system, 2, equality between men and women, and 3, economic growth that we have been highlighting for several years now. This triple dividend could result from recognizing and promoting women's role in health, as well as the immense economic value they represent. We talk about a 5% contribution to the global gross domestic product. In other words, $3 trillion US. That is huge. I therefore call for this initiative to continue to mobilize, to engage, and to enable concrete actions at the national level, and I wish you fruitful and successful discussions. I would like to take the opportunity to thank our co-sponsor of the event, the government of Liberia, and of course, our partner, Women in Global Health. Thank you very much.
Thank you very much, Ambassador Delphine. And really, I want to especially thank you for calling for concrete action and for us to have a recognition of the role of women, not just in one small sector, but certainly also in the general health system, and also just expanding on the fact that, in fact, it's not just about health, but certainly looking at the lens of the economy as well. So thank you so much, Ambassador Delphine, for that. I'd now like to invite Dr. Martha Robolo, who will give us an introduction to Women in Global Health and the organization's work to highlight and understand women's unpaid work in health. Martha is Managing Director of Women in Global Health and has decades of experience working in the fields of public and global health. She was also the Minister of Public Health in her home country, which is Guinea-Bissau, and one of the only women in the world to lead a national COVID-19 task force. And since her, there have been a number of women who have led COVID-19 task forces nationally. but certainly Magda was a pioneer. And she has also worked with the World Health Organization for many years. Magda, the floor is yours.
Thank you very much, Moderator or Deputy Dean. On behalf of Women in Global Health, especially on behalf of its Executive Director, Dr. Rupa Das, it gives me great pleasure to welcome all our eminent speakers, our moderator and audience for this event today, which marks the Commission on the Status of Women taking place at the United Nations headquarters in New York this month. Especially, I would like to acknowledge Her Excellency Honorable Minister of Health for Liberia, Ambassador, and our co-partner in this initiative, Ambassador at Large, Delphine Ho. Our event today, Economic Empowerment for Women Health and Care Workers, the impact of COVID-19, focuses on the CSW review theme for this year, which is women's economic empowerment in the changing world of work. The theme is highly relevant to the health sector at a time when the whole world has entered the third year of a devastating global pandemic, and because 70% of the health workers are women. The world of work is changing fast for women health workers, but not always in the right direction. I want to thank our partners in this event, the governments of France and Liberia. It was a pleasure to listen to the insights of Ambassador Delphine of France on the Gender Equal Health and Care Worker Initiative, and to learn how commitments to women's rights and gender equality made at last year's Generation Equality Forum will be followed up for accountability and for impact. Women in Global Health were proud to launch the Gender Equal Health and Care Worker Initiative with France and WHO last year, 2021, because we recognized that health systems cannot function without the work of women. At the same time, we recognize that the extraordinary service of women health workers in the pandemic and even before the pandemic has not earned them an equal say in decision-making. Women hold only 25% of leadership roles in health, and there is worrying evidence that women have lost ground in health leadership since the pandemic began. Women are the experts in the health systems, they know best, but their expertise and diverse perspectives are not valued sufficiently to guarantee them equality in leadership. COVID-19 has shown a harsh light on the fragility caused by these structural gender inequalities, and it has widened inequalities between and within countries. The Gender Equal Health and Care Workforce Initiative that Women in Global Health lead with France aims to inspire action for gender equity in the health sector in 4 pillars. The first pillar is about promoting equal participation of men and women in health leadership. The second pillar is about recognizing the value of unpaid work, largely done by women in the sector, and the importance of equal pay. The third pillar is about protecting women health workers against violence and harassment. And fourthly, ensuring safe and decent working conditions for health and care workers everywhere. Gender equity in the health and care sector builds a strong foundation for health systems, for universal health coverage, and for global health security. I'm pleased to note that in less than a year, the Gender Equal Health and Care Workforce Initiative has convened the international community, focused attention on the critical issue of gender equity in the health workforce, and that over 40 governments, international organizations, and NGOs have made commitments and expressed their support. We thank all the governments and organizations that have joined the initiative, with special thanks today to the governments of Liberia, United States, and Australia who are with us and speaking at today's event. We are delighted that Ambassador Jane Clark joined us and she'll be announcing Australia's commitments to the initiative today. COVID-19 has changed the world profoundly, causing death and devastation now and aftershocks that will scar future generations. This is our opportunity to rebuild global health on a stronger and more equal foundation and ensure that women who deliver health and social care are leading the systems they know best. I will hand back the floor to our moderator, Flavia, now, and I will be listening carefully and with great interest to our inspiring speakers for today. Thank you very much.
Thank you very much, Martha. It's really just such a great honor. And I look forward to welcoming you back to the stage when we do the panel discussion later on. And it gives me great pleasure to invite Her Excellency, Dr. Philomena Jala, who is the Minister of Health of the Republic of Liberia. Minister Jala is a dedicated and patriotic medical doctor with over 25 years of national and international work experience in clinical sciences and public health management. Minister Jala is also the chair of the country's Incident Management System, which is abbreviated IMS, and she's also responsible for the implementation of the country's national COVID-19 preparedness and response strategy. She's committed to strengthening delivery of primary healthcare services while responding to the pandemic. And prior to becoming Minister of Health, which was in March 2018, Dr. Jala served as founder, chief executive officer, and medical director for 6 years of 2012 and 2018 at the organization that was called Hope for Women International Medical Center in Liberia. And as the new Minister of Health for the newly elected pro-poor government, Minister Jala's vision and mission is to transform healthcare delivery through hard work, transparency, accountability, and good governance. Dr. Jala's overall objective is to ensure that health services in Liberia fall in line with the UN Sustainable Development Goals. Colleagues, Your Excellency, the floor is yours.
Good morning to all, Madam Moderator, and other distinguished panelists. I bring you greetings from the Republic of Liberia, our feminist in chief, the President of the Republic of Liberia, President George Manenwia, and the women of Liberia. It is my honor to be here with you all today. In Liberia, the movement we find ourselves in is informed as much by the current pandemic as the last health crisis we faced was Ebola. During the 2014 and 2015, we were able to recover from that. After Ebola, we now have to be challenged with a pandemic that we all face around the world. Now, for Liberia, how we tackle this pandemic, because a lot of the patients had another mistrust in the health system, we had to introduce and capitalize on our community health program. This program has trained over 4,000 professionals, community health workers. Currently, it's sad to say that we have only 17% of these community healthcare workers are women or girls, young women or young girls. But it's pleasing to say that the community health service supervisor, 51% of them are professional nurses that supervises the community health workers. Among some of the striking things that these community health worker does at the community level is to have brought our malaria control in children to over 45%, our under 5 diarrhea and malnutrition status for all these people at the community level are improving. This program is essential for Liberia's pursuit of universal health coverage, and it has emerged as a global example of high-quality community-based care. For 5 years into this program, we know that there are a lot of potential that can be increased. The National Community Health Worker Program aims to give preference to the recruitment of more females to harness the gender-focused benefit like economic empowerment and improve the literacy and social status of women. Despite this, only 17% are women. With this in mind, we have committed at last year's General Equity Forum in partnership with Last Mile Health to increase the number of women who serve as professional community health workers in Liberia. Since then, we have learned a lot about the barriers that these women are faced with in the community. For example, we still have issue where women should still be in the house taking care of the children and cooking the food and serving the men. So how can we get them out of that phase and bring them into the workforce to increase the gender disparity? We have conducted a comprehensive gender assessment of the National Community Health Assistance Program, and we found that gender expectation and cultural norms often restrict the women to household activities. Education and literacy requirements are a common barrier, given the significant challenges to many girls face in completing school. So one of the things that we are going to be doing, we are going to go to the high schools and begin to recruit the girls as community health workers, because it's only 4 hours of work per day. So they can still go to school full time and acquire an education, do their community health services, as well as their household chores. And we have to also introduce to the men that they can help in these household chores to allow the women to go and go do community services. So we are looking ahead as we plan to undertake the changes in our program policy. And with our partners, we hope to provide an enabling environment for female community health workers in terms of making sure they are secure when they go to the different communities as well as household, to protect them from any sense of sexual and gender-based violence. When we put together the center of our health system, everyone's benefit. More female community health worker means higher quality primary health care for women and families, and it means greater economic empowerment for women health care workers. I want to thank all of the women in global health, my co-sponsor, the government of France, and all of our listeners, that community health worker taking health to the community works. Thank you for listening.
Thank you very much, Excellency. I mean, I must say that there's so many things that resonated with me, and I'm sure also resonated with our audience as well. Your keynote address was really thought-provoking, and we want to commend you on the incredible work that the Ministry of Health in Liberia has managed to achieve under your leadership, especially towards advancing the rights of community health workers, which really in many of our countries are a cadre of workers that certainly deserve a spotlight and recognition. So congratulations, Minister. It's really just fantastic. I now have the pleasure to present Ambassador Christine Clark, Ambassador for Women and Girls for the Government of Australia. And prior to commencing the role of Ambassador for Women and Girls, Christine worked with the Pacific Gender Section in the Department of Foreign Affairs and Trade on reserve services following completion of her lengthy full-time Navy career, which she completed in June 2021. Ambassador Clark served as Australia's Defence Advisor and Attaché to New Zealand, Cook Island, Chile, and that was between 2018 and 2021. She was awarded a Conspicuous Service Cross in the Australian Day Honours List, and that was in 2013, and it was for excellence in leadership. As a command and a committed LGBTQI+ ally, Ambassador Clark led the Department of Defence contingent in the Sydney Mardi Gras on 2 occasions. And now welcome Ambassador Clark's video message.
I begin today by acknowledging the traditional custodians of the land on which I am speaking from today, the Ngunnawal people, and pay my respects to their elders, past, present, and emerging. Firstly, let me congratulate the Government of France and Women in Global Health for partnering on this important agenda, achieving a more gender equal and representative health and care workforce. We know that gender equity in the health and care sector builds a strong foundation for health systems, universal health coverage, and global health security. We also know that while women deliver global health, men often lead it. Health systems will be stronger when the women who deliver them have an equal say in developing national health plans, policies, and systems. Occupational segregation by gender runs deep and is universal. Women are highly represented in nursing, whereas more men are surgeons and fill executive roles. Wider societal gender norms and stereotypes reinforce this. In Australia, we have made some gains with increasing female representation in the medical workforce. 43% of doctors in 2019 were women, an increase from 40% in 2015. Yet we still face challenges with equal representation in national medical leadership positions. As recently as 2019, women represented only 33% of medical deans in academic institutions and just over 12% of hospital chief executive officers. Australia is committed to addressing these issues through our recently developed National Medical Workforce Strategy to embed good practice and flexible training pathways that promote gender equity. Through Australia's International Development Program, we are also investing in women's leadership and empowerment in the health sector through a range of programs. Our support to the Royal Australian College of Obstetricians and Gynecologists enables women in medical roles across our region to access mentoring and clinical placements in Australia to advance their leadership opportunities. In PNG, the PNG Australia Transition to Health program has an explicit focus on improving women's leadership in provincial health service delivery. And Australia also advances these important issues, such as the prevention of sexual assault and harassment, through our multilateral engagement. In addition, we know that pre-existing inequalities influence infectious disease risks and impacts. This has been borne out in the disproportionate impact experienced by women and girls throughout the COVID-19 pandemic. Our government recently announced a further 5-year, $375 million investment in our region's health security to strengthen health systems and help us prepare for emerging infectious disease outbreaks. With this funding, we are seeking to make tangible differences in health and specifically the impact of health insecurity on women and girls. Australia is also supporting emerging leaders through the Australia Awards Scholarship Program who are making a difference to their countries and our region as a whole. Women like Dr. Pamela Tollerman, a senior scientist responding to COVID within the PNG Institute of Medical Research, and Adi Vasiti Radhanavuna, the first female director of Fiji's National Disaster Management Office with a leading role in Fiji's pandemic response. So let me conclude by affirming Australia's support for the Gender Equal Health and Care Workforce Initiative, a commitment to increase the proportion of women in health and care leadership roles, recognise the value of unpaid health work and equal pay for women, and ensure women are safe at work, including from sexual harassment and violence. Only by increasing visibility of the issue, maintaining a dialogue and committing to action on gender equity in the health and care workforce will we achieve change. Australia is a proud partner in this endeavour. Thank you.
Thank you very much to Ambassador Christine Clark, who again, as I said, is the Ambassador for Women, Girls, in the Government of Australia, for that absolutely inspiring message that I think not only showcases the work that Australia has done, but certainly also is a point where all of us can learn and look at some of the programs that have been implemented in Australia and see in terms of the fit in our own countries. And so as a final intervention before we move on to the panel discussion, I'd like to present a video message from Ms. Margaret Odera. She is a mentor mother for women living with HIV, a certified community health worker, and an advocate who is working in Kenya. Margaret advocates for community health workers to be recognized as important members who are of the health worker teams and compensated fairly for their work. She has campaigned for health workers to be provided with personal protective equipment and digital tools they need to keep themselves, their families, and their patients safe during this COVID-19 pandemic. Margaret, the floor is yours.
Thank you very much. My name is Margaret Odera. I am a community health worker and a mentor mother living in Magare slums and reporting to Magare North Health Center. As a mentor mother, I mentor HIV positive, pregnant and lactating mothers to make sure that we have eradication of mother-to-child transmission of HIV. As a community health worker, I do mobilizations, I do sensitizations, I do linkages, I do referrals, and I do follow-up. Following up the members of my community so that we may avoid having defaulters. And this results to death. So I make sure that I follow up the HIV patients, the TB patients, the high blood pressure patients so that we may have adherence of drugs taking place in our community. I act as a bridge between the community and the facility. So I link the community members to the specific places concerning their issues. For example, if a person has mental problems, I will refer them to MSF where there are experts who are dealing with mental issues. I also mobilize the community, preparing them when we have vaccination campaigns, when we have family planning campaigns. I mobilize the community days before so that they may prepare to welcome even the people from the hospital when they come to vaccinate them. Example is polio and measles campaigns and also COVID vaccination campaigns. In sensitization, I sensitize the community on the importance of hygiene because outbreaks were so rampant in our slum. But right now they have reduced. I am so grateful. What motivates me is as a mother myself, as a person who has lived with HIV, I have lived for 22 years and I've been healthy. This itself motivates me. The fact that I have 3 HIV negative sons and my husband who is HIV negative is a motivation for me myself. And this drives me to be an example even to my community so that we may have a healthy community. The impact that I have created in the community is a very, very positive one. In 2017 to 2021, I mentored 604 mothers whom all their babies at 18 months turned HIV negative. The positivity rate in the community is below 2% for the mother-to-child transmission of HIV. And this is a satisfaction for me. I advocated for boreholes because of lack of water in my community. And right now, we have more than 3 boreholes in Mathare. So that is a good impact. I work as a volunteer, community health worker. And all the community health workers in Kenya are volunteers. And so there are ongoing talks with the government so that we may have a stipend. And this will make a difference in my life. Because as an immunocompromised mother, I will start eating good food. Because right now I don't have a choice. I eat whatever comes my way. But when I get a good salary, I will eat right. I will eat good food. My children will be comfortable because they will know that mama is going to bring something at the end of the month. And this will motivate me. I'll be happy when I see my children are happy. I'll be responsible even in my government because I will be paying taxes. And this will be giving me a sense of responsibility as a Kenyan citizen. In future, I would like to go back to school. And I finished high school. I got basic education with Colping Vocational Training Center. And I wish to be a nurse. So if I get an opportunity, I will grab it. And for this, I want to thank you for this opportunity. God bless you so much.
Thank you very much for that powerful message, Margaret. I mean, colleagues, we always talk about the community health workers and what a joy to actually put a face to a community health worker. And not only that, but to actually hear her story. And so thank you so much, Margaret, for your story and for your voice and for standing in the gap of community health workers. I now have the pleasure to invite Martha back to the virtual stage and to introduce her fellow panelists. The first panelist is Dr. Angela Achireka, who is the Principal Deputy U.S. Global AIDS Coordinator, a Principal Deputy Assistant Secretary level position. As such, she serves as the second in command to the U.S. Global AIDS Coordinator and supports the daily oversight, coordination, leadership, management, and implementation of the U.S. President's Emergency Plan for AIDS Relief, which we all know as PEPFAR. And PEPFAR is there to ensure that all its activities, resources, including its annual budget of approximately $6 billion in over 50 countries, is as impactful, effective, and efficient as possible. Dr. Achireka has dedicated her career as a public servant to global HIV and AIDS, women and girls health, and global public health development. She holds a doctorate in public health from the University of North Carolina at Chapel Hill, a master's of public health from Yale University, and a Bachelor of Science from the University of California in LA. She has lived and worked in numerous countries across Asia and Africa, and she speaks multiple languages. I really want to warmly welcome you, Angela. And then it's a pleasure to welcome Dr. Shabnam Safaz. She's a health and development professional with over 15 years of senior leadership experience. And by qualifications, she's a medical doctor with an MBA from the University of Surrey, a postgraduate certifications from McGill, Johns Hopkins, and Harvard University. She's currently serving as a member, social sector and devolution at the Planning Commission in the government of Pakistan, and managing the complete portfolio of social sector, which includes health, education, gender, population, sustainable development goals, manpower, and social welfare. She is also leading the COVID-19 Secretariat. Dr. Safaz has been a visiting scientist at Harvard Global Health Institute. She is also a Charles Wallace Scholar and a Harvard Lead Fellow of the inaugural cohort. She is also the co-founder and country lead for Women in Global Health, the Pakistan chapter, which is working to address gender parity in the health workforce. And I must say, Shabnam, that I've seen excellent work coming from the Women in Global Health Pakistan chapter. So I want to warmly welcome you, Shabnam. And so colleagues will now start this panel discussion right away. And I want to start with you, Anjali. If you could just tell us a little bit why the health workforce matters in the work that's done by PEPFAR, and what steps you think are necessary that we need to take in order to promote gender equity. Over to you, Anjali.
First, thank you so much, Professor Flavia. And let me first begin by thanking Women in Global Health and the governments of France and Liberia for convening such an important session. And personally, I'm very humbled to be a part of a session with such extraordinary women leaders. So thank you for inviting me to join. To your question about the workforce and steps we're taking within the US government to promote gender equity. First off, the health workforce in the broadest sense, doctors, nurses, counselors, community health workers. We just heard from Margaret as a mentor mother who was extraordinary, laboratorians and others. The health workforce doesn't just matter, but it is essential to the work that we do through the President's Emergency Plan for AIDS Relief with countries and communities to provide HIV prevention and treatment services and those broader system supports to all those in need. The US government through PEPFAR is deeply committed to gender equity and inclusion in everything that we do. For example, we invest nearly $2 billion annually in direct bilateral support for women and girls to be healthy and achieve their dreams across more than 50 countries. We have a long-standing commitment to women and girls to yield life-saving results. Last year, for instance, through a public-private partnership that we are engaged in called DREAMS, nearly 3 million adolescent girls and young women were reached with comprehensive HIV prevention services. And over 11 million women and girls are supported through PEPFAR with countries with direct life-saving treatment. Our mission is to sustainably control the HIV epidemic together with countries and communities. And as part of this effort, PEPFAR employs nearly 300,000 healthcare workers around the world. And approximately 2/3 of those are women. Advancing women's rights in space is key. Of course, gender equity in the health workforce is central to achieving our mission. The other piece that I'd highlight is that we're really pleased to share that in alignment with our national strategy on gender equity and equality, we have taken major steps to promote gender equality and equity in our annual planning this year through PEPFAR. So for the first time ever, our annual planning with countries, which provides guidance for our investment of over $5 billion for the HIV response, includes a large section on gender equality. And we're really using the moment in front of us to focus our resources together to complement government resources, multilateral resources to really advance gender equality and equity, gender equitable, gender affirming, trauma-informed health and social services, for example, a workforce that advances women, non-binary, and gender minorities and leadership opportunities, for example. We have minimum program requirements in which we're prioritizing local women-led organizations as direct funders and implementers of programs. These are just a couple of ways that we're trying to advance these efforts. So in sum, Professor Flavia, the health workforce and women in the workforce and protecting them not only matters, but is essential. And the US government through PEPFAR continues to prioritize this. Thank you.
Thank you very much, Anjali. And I must say, coming from South Africa and having seen the incredible work that PEPFAR does in our country, and certainly one of the things that has stood out for me working with colleagues who have been supported by PEPFAR has been certainly the gender lens, and how many of those colleagues, have found themselves not only just working in these programs, but certainly, Anjali, leading these programs. So thank you for the insights into the important work that the US government is doing to promote gender equity. I want to now turn it over to you, Dr. Shabnam, and if you could just tell us a little bit about how things are in the government of Pakistan and how the government in Pakistan is working to promote gender equity in the health workforce. Over to you.
Thank you so much. I wanted to thank all the organizers for it's a very critical subject, really. And I'm both honored and privileged to be part of this esteemed panel. As a UN member state, the government of Pakistan is signatory to the Agenda 2030, that is all the 17 goals, the targets and indicators under them, and one of the first countries to formally endorse the same through a unanimous parliamentary resolution. Pakistan is also committed to CEDAW, the Beijing Platform for Action, the Child Rights Convention, all directed to ensure women's rightful place in the society. In the past years, there has been notable progress attributable to more deliberate investments in improving the lives and well-being of both girls and women. Gender development has been highlighted as a priority agenda by both the Honorable President as well as the Prime Minister of Pakistan. However, with this highest level political commitment in place, as technocrats, we recognized our responsibility to guide both institutions and employers towards addressing injustices and promoting equity. I strongly feel that an organization's moral and human rights and justice compass is led by the people who are steering it. There is commitment to a goal, and then there is action and requisite dynamism around it. Let me elaborate a little. At the Planning Commission, I lead the entire national social sector portfolio, which includes health, population, gender, education, youth, and sustainable development goals. Due to my association with the cause of gender equity in health workforce and my health background, I have been in the unique position of accelerating and galvanizing the movement around gender equality in health workforce. This started in 2019 with the formal launch of Pakistan's Women in Global Health Chapter. This was inaugurated by 2 sitting ministers, attended widely by parliamentarians, policymakers, academicians, and frontline workers, clearly indicating the government's buy-in and serious commitment. In 2020, right before the pandemic, I led a study on gender equality in health leadership. This captured perspectives of 85 senior women leaders, a study that was picked up by my peer lead fellows at the Harvard Global Health Institute, who replicated it in Moldova and in India. This study has been pivotal as it is guiding development of a case for more women representation in leadership roles across the health sector in Pakistan, and we are continuing to use this evidence for our advocacy purposes. As we got global recognition for our COVID-19 response, the government of Pakistan widely recognized that our health response was delivered by a health workforce which comprises of 76% females even today. The government supported a study on experiences of frontline female health workers amidst the pandemic and accordingly budgeting for their resources and protection, which is a national commitment Pakistan made during the Generation Equality Forum last year for women health workers. Again, using the space that I was occupying at the Planning Commission, I led another study for the Ministry of Planning on gender parity experienced by its female staff. As we disseminated the evidence in December, the government of Pakistan asked us to roll out this study in its 42 ministries, which is currently underway, including the Ministry of Health, and has already committed funds for making the public sector workplaces gender conducive. Gender focal persons have been identified in all these ministries who will be rolling out these initiatives and will report back on their respective gender monitors. This has been a key advocacy and policy win. Recently, on the 8th of March, which was the International Women's Day, the Minister of Planning, together with the Minister of Human Rights, launched the country's first ever National Gender Development Policy Framework with pivotal decisions which have implications for governance to ensure that what we are committing actually happens. And I was privileged to steer with a village of strong-willed women from all across the country, from different sectors and specialities who helped put this framework together. I feel these are all serious commitments in terms of policy directives, resources, and accountabilities on part of the government of Pakistan.
Thank you very much, Dr. Shabnam. And I mean, I want to steal your words about the village of women. And I think I speak for the global village of women when I say, when you echo the fact that it's not just about commitments, but it's actually about committing and ensuring that in fact there is action, and also the recognition of civil society organizations like Women in Global Health Pakistan and the government of Pakistan support for civil society organizations like those as pivotal partners of driving this women agenda in Pakistan is just absolutely commendable. And I really want to congratulate you on that. I want now to just turn it over to you, Martha, as a former Minister of Public Health in Guinea-Bissau. What was the status of women in the health workforce?
Thank you, Flavia. Let me start by saying that I had the privilege of being appointed Minister of Public Health in the first gender equal government of my country, first and only one to date. I came and found a situation which was no different from what we see across the world. Majority of the health sector is made by women, and they have a very low status within the health sector. Women in Guinea-Bissau, just to give you an example, the majority at the largest maternity ward in the country, in the major hospital, but the maternity ward has never been led by a woman. So most people, most healthcare workers working in the maternity, taking care of women, giving birth, is consistently led by men. And women in the sector of gynecology and obstetrics, they stop at the midwifery level. And you have men leading such an important and sensitive area for women. Just to give you an example, we have 11 health directorates across the country. Only 2 are led by women, and one of them was appointed by me. Unfortunately, she succumbed to COVID-19, and I want here to honor the great work she did in the capital, leading the regional team during COVID-19. So you'll find women in the lower and middle level positions within the Ministry of Health. And when I was there, I made sure that my cabinet was majority women, including appointing a woman as Inspector General for Health, which was such an important position, just to bring that's pride and lead by example, giving women the opportunity to lead and demonstrate that they can do even better work than men do. To tell you, the situation in Guinea-Bissau is compounded by widespread level of female genital mutilation. So far, one of the major challenges where the focus is to end female genital mutilation. Women in parliament are majority, only 14% of parliamentarians are women. Women in government are minorities. So this reflects also in the health sector. We are working with my foundation to bring women in the health sector to build confidence in themselves so that they can become more aspirable to positions of leadership. But in a nutshell, the healthcare sector in Guinea-Bissau is delivered by women and led by men, unfortunately. Thank you, Flavia.
Thank you so much, Martha. And I mean, I'm smiling because that's the next question that I have, in fact, and I want to throw it back to you, Anjali, as Martha has said, you know, that we only hold 25% of senior roles in the health sector. I mean, should we be concerned that men hold majority leadership roles? You know, for instance, I mean, a lot of the people that we've interacted with and that we, you know, who've come to our country from PICFA have been men. And it's a joy to see you, Anjali, you know, as a woman leading this particular space. And I mean, my question maybe to all of you, should we be concerned that men, you know, are holding these positions and we only have 25%? Anjali?
Thanks so much for that question, Professor Flavia. And I think, Magda, your last sentence was so poignant when you said, you know, that men lead the health space and women deliver in the health space. And we have to bridge that gap. I mean, this is, so am I concerned? Yes, very concerned about that. You know, we should be concerned with this in the case, you know, as we're concerned with all of it, every time we see a gender disparity. Leadership disparities have direct impacts on the people we serve. You know, if women are only 25% of the senior leaders in the health sector, then our field is not benefiting from the best and brightest of half of the population. And more importantly, you know, the people we serve are missing out on the sensitivities that were described in the example of the OBGYN and the midwifery case that you just talked about, but also the ideas and contributions that women leaders could be making. You know, women continue to be disproportionately affected by inequalities that impact their health and livelihood, but they're often left out of decisions on policy and program and leadership roles, just as you framed in the question. When we look in the PEPFAR space, when we look at the most senior clinical cadres, doctors, clinical officers, pharmacists, for example, that we're supporting through PEPFAR, we find that roughly 42% are female. So although this exceeds the 25% that we were just sort of talking about, we realize this is a problem, and we're striving to do better so that we can increase women leaders in the health workforce, so that we're really making sure that we represent the population. But thank you for raising this question, this disparity. I think it's very, very critical and very concerning. And hopefully collectively, by shining a light on it, we can really, close that gap that we see. Thank you.
Thanks, Anjali. Dr. Shabnam, your comments?
Well, I think we should not be concerned that men hold these roles, but moving forward, we should be concerned that only men should not continue to hold these roles. Role of women as drivers of health needs to be acknowledged. Their experiences need to be accounted for in policymaking and in program design. We need men allies, yes, but we need more directed women leaders too. And we've seen, and this has been demonstrated, that during COVID-19 pandemic and even otherwise, when women are there on the policy table, the decisions that they take in the interest of women and children particularly are much more robust and evidence-driven. So we would need to march towards that, certainly.
Thank you. And I mean, one of the things, I mean, which is incredible about the Women in Global Health platform and the work that all our colleagues and our esteemed distinguished ambassadors and the ministers have been talking about is women must lead. But something that is very interesting about the Women in Global Health is that we do have a cadre of young professionals, professional women who are on this, panel. Martha, how do we get our young women who we know most of them will reach middle level management, and then they will just say, you know what, I don't want to be, Anjali, I applaud her, I applaud Shabnam, but it's just not for me. How do we get young women? I mean, we're talking about capacitating, bringing people in, and ensuring that there's a sustainability for young women to come through. How do we make sure that these young women put their hands up and say, I've heard about the inequity, and how do we bring them in and how do we support them so that they become the women leaders that we want? Over to you, Martha.
Mm-hmm. That's an important point, Flavia. Throughout history, women leaders have existed. The problem is not being capable, competent, skilled, and having abilities to lead. I think the work we are doing and bringing to the fore role models is very useful to help them break the stereotypes they have, but there are values in society that we need to continue working on. Women that should be aspiring to break the glass ceiling and entering the boardroom, sitting on the table, are still trapped with domestic work, childbearing, educating children, taking care of their husband, and being trapped in marriage where the spouses are intolerant and they are still demanding that women get home very early. And these are the more powerful barriers preventing women from leading and ascending to positions of leadership. And these are more difficult to remove because the entire society surrounding women are still putting pressure into those women who would prefer to stay in a stable marriage, have a relatively comfortable job, rather than being in the limelight and working extra hours, coming home late, and having to hear people thinking that probably they are not good mothers because they are not taking care of the children. Probably they are not good spouses because they are not home to cook and take care of their spouses. These are some of the challenges we still need to work on. But then there is another big challenge as well. Men need to accept to work with us in a very positive and constructive allyship mode and step down whenever there is equally or even more qualified women who can take up that position. Look at the international organizations, global health organizations. Most continue to be led by men. And if you move down, you still have more men than women leading those organizations. It is more difficult to implement policies and strategies that will bring gender equality into the workspace of global organizations if men despite the nice statements, don't actually make space for women to lead. So we have to work in different fronts, but men as allies is an area where we need to do a lot of work in order to create space for women to, it's not making us a favor, but it is as long as they continue to hold on to power, it is going to be difficult, but we will not relent. Thank you.
And I mean, thank you so much. That is, I mean, just such a powerful statement that you've made right there. And I mean, when we talk about allyship of men, one of the things that shocked me, Anjali, is just realizing and seeing it written that women contribute around 3 trillion to health annually, but around half of that is in the form of unpaid work. You know, maybe they should be allyship around unpaid work, Dr. Martha. But what I really want to ask Anjali is, how can we ensure that women health workers are fairly paid in the extraordinary work that they do? A lot of the work that PEPFAR is doing is really, you know, ensuring that you do have women in your various spaces. How are you ensuring that there is a fairness in payment of women? Over to you.
Thanks for that question. And I think, you know, this comes back to, you know, if there's commitment, that's great, but it's not enough unless you put resources behind it to really act on that commitment. And so what we've attempted to do and tried to do is really push in the PEPFAR space. So we have provided guidance to all through our planning to ensure that decent work and fair pay is essential, you know, for PEPFAR programs, for community health workers, you know, for healthcare workers, so that they are receiving fair remuneration for their efforts. Again, especially for community lay workers, peer counselors, peer workers, like Margaret described how important that would be. A specific example of how we're implementing this is through the DREAMS partnership. Flavia, you mentioned the public-private partnership and your experience you've witnessed in South Africa with it. But again, DREAMS is focused on HIV prevention for adolescent girls and young women in 15 countries. And we really are pushing through this program, for example, to make sure that the main cadres implementing DREAMS are number one, you know, have safe spaces, are protected themselves, but are also able to have fair pay. I mean, we are ensuring that, you know, when we reviewed, and this is, you know, we launched this in 2014 and we've been at it for some years, but when we review mentors that we have hired through the program, we realized that some, in fact, were being asked to volunteer for their time. Of course, this is unacceptable. So we made it very explicit in our guidance that mentors should receive sufficient remuneration and resources that reflect their efforts, their work. And this is something that we're trying to monitor very regularly to make sure that resources match the commitment that we have.
And I think that's such an important statement that you're saying, Anjali, about the resources matching the work. And I mean, Martha, I want to now turn it back to you and talk a little bit about, you know, how do we ensure that really resources match their work? Martha, what are some of the thoughts and maybe the things that you've done during your term?
Thank you, Flavia. Here, I want to stress the importance of data. We need to work continuously to bring to light data related to unpaid work, so that we can continue sensitizing people. In some places, like in my country, for example, there is no data to quantify how many women are in unpaid work and what does that represent to the economy. So unless we bring statistics to the debates, it will be more difficult. And I think $3 trillion is such a huge amount of money that people don't realize what exactly the work of women represents. I think policies and strategies
I think we've lost Martha. So I'll move over to you, Dr. Shabnam. I mean, one of the points that Martha was talking about is in terms of, you know, this, in terms of equal pay, is also, of course, something that we don't routinely talk about. Is yes.
Yeah, and this is in Guinea-Bissau 2 years ago, we passed after a strong push by a group of civil society and a group of women parliamentarians, they passed a law to bring 40% of women into government positions, but also to make women in positions of being elected within political parties. And that rule is not being respected. But that's one way, and probably one of the most important ways, at least for Guinea-Bissau, to get women into positions of leadership through decision-making bodies, be it parliament, government, etc., and then be able to have the instruments, use them to change the rules, the laws, and the policies that will bring impact on the ground. There is a lot of civil society organizations and grassroots organizations led by women to try and change the status quo and move the gender equity agenda forward. But when they move up to a certain level, then they are confronted with the fact that men are in the position of power, and those issues become less important and don't have priority. But to conclude, to me, data is, gender disaggregated data is something we need to focus on. We need to bring more data, more evidence to the debate, to the discussions, so that we can continue advocating for gender equity and uncovering so much damage that is done to economies, to tourism and many other areas, education, etc., because of the fact that gender equity is not yet a norm in our countries.
Yeah, I mean, Dr. Shabnam, that for me, Martha ends off on a powerful point, and I always say that, and I say it as a woman who is African from the Africa region, that women have always led. It's only here in modern society where we think it's a strange anomaly that women are leading. But the reality is that there is one of the things that I absolutely loved in one of the sessions that I attended in the chapter, the Pakistan chapter of Women in Global Health, is where they talked about these safe environments. Dr. Shabnam, in your opinion, could you pick up around how do we create safe environments for women, you know, in the positions where a lot of times, even when they're in this position, there'll be one or two of them and men around them. And that environment sometimes is not really safe. Your voice is not heard, your words are not really taken, you're minimized, you're invisibilized. There's also another layer. We talked about the community health workers, and that safety is a little bit different in terms of its definition. It's about creating a safe environment because the women are going door to door. And how, in your experience, have you made safe environments for even the community health workers as well as they deliver their services? Over to you.
Thank you. I was recently reading the WGH's latest report, Fit for Women, Improving Personal Protective Equipment for Women and Healthcare Workers, which surveyed more than, I think, 1,000 healthcare workers. And it points to the increased health risks, including the mental distress for female health workers. Only 25% of the women reported having an adequate supply of PPE all the time. This is consistent with our study as well that we did in Pakistan, and therefore also reflects Pakistan's commitment for gender equality in health workforce. More importantly, everything we do during and after the COVID-19 crisis must aim to build more equal, inclusive, and sustainable economies and societies. I think COVID-19 did bring us this opportunity for a more equal, approach. This implies extending basic social protection to informal workers, giving special attention to the health, psychosocial needs, and work environment of frontline female health workers, including the community midwives, the nurses, the health workers, as well as the facility support staff, which are in Pakistan, they're all females on the front line. This size appropriate, again, the PPEs, mask, and other operational gear, essential hygiene and sanitation arrangements, protection, and clear measures need to be in place to prevent and mitigate abuse and gender-based violence. The voices of women on the front line must be included in response planning. It's very important for them to be on the tables to share their concerns and to voice them so that all these become part of the policy decisions which are being made and policy reform initiatives that we carry forward. So having these women on the table, and for the few of us who are on the table, raising it and being the voice for those who are not there, I think it's critically important, very, very important.
Dr. Shabnam, thank you so much. And a lot of what you've said resonates quite deeply with me. And I really have enjoyed this panel discussion. And I want to now just ask you, or if you had a magic wand, what is the one policy measure in your view that you think would have most impact on gender equity in the health workforce as we wrap up in terms of your final words? Dr. Anjali, I'll start with you.
So thank you for that question. If I had a magic wand, I think I would say one of the most impactful policies in the health sector would really center around closing the gender gap of women in leadership roles. Women in leadership roles will then translate into the policy environments, the supportive environments, the programmatic efforts that we wish to see with greater gender parity. So I think it really is creating the space for women to rise up as leaders, the leaders that they are.
Thank you so much. Dr. Shabnam?
I think there are three key elements to consider here. A foundation for equality that addresses national social norms and stereotypes, a government directive fixing labor markets, and a system and culture that enables women. For the foundation, investment in care and transforming economic and social policies that incorporate gender justice as an objective is crucial now and in the future. Pakistan has just done this with its gender development policy framework through an inclusive and collective process, ensuring local ownership, committing resources, and charting out accountabilities, prioritizing the investments where they are needed the most, according to the budget limitations that we have, and establish pressing needs which need to be addressed first and foremost. I think that's extremely critical. Finally, I think the enablers, all these policy measures need to form part of a health sector specific gender transformative policy guidance that can push the health sector into a leading role in empowering women and girls and achieving the gender equality. This is needed more now than ever.
Absolutely. Dr. Martha?
Well, I think I subscribe to the proposals made by the two panelists that I'm enjoying this platform with. I think one important issue that keeps holding women back is economic disempowerment. Lack of freedom in the economic fronts makes women more dependable, more dependent. More dependent, not dependable. We are dependable, but many of us are still depending on their husbands or other people to support them with education for their children, and therefore they cannot afford to be in the forefront and lead. I think economic empowerment across the board in the healthcare sector, making sure that a social contract is established to eliminate unpaid work for women will go a long way in empowering them into positions of leadership.
Thank you so much. And I really want to thank our panelists so much. I've enjoyed this panel discussion, not only just enjoyed it, but also learned so much from all of you. And it's a great honor for me to sit here with you as exceptional sisters in the village, to borrow Dr. Shabnam's word. It's been a great honor for me to moderate this exceptional, this exceptional program. And I want to thank all our distinguished guests, our speakers and panelists. And I want to now turn it over to Martha to close us up. Over to you, Martha.
Thank you very much, Flavia. We have 1 minute to go, and I would like to take this moment to thank all our speakers and panelists today for the insights and commitment to driving gender equity in the health and care workforce in order to strengthen health systems and global health security. I want to thank you, Flavia, for your fantastic and lively moderation. I will not have much time to express a number of very good ideas that came out of this panel, but I would just like to thank all the governments who have joined us supporting this initiative, and we look forward to working with many more organizations and governments to expand our reach and be able to make gender equity in the health and care workforce a reality. We thank you so much. Women in Global Health is proud to be with you. Thank you, everyone, for joining us today. We hope you stay the course. Thank you.
Thank you.